Thank you very much, my dear friend, and thank you very much, all professors and chairman. And I would like also to thank you for your attendance this morning. Hopefully that this will be a very successful Congress. And I would like also to deeply thank all the working group contributors and the approval team, and especially thanks to professors from different countries, from different universities and reviewers, and from everyone who shared the thoughts written reviewing all the guidelines in hemodialysis. And very special thanks to senior professors who reviewed in depth all the guidelines parameters. So in this year, starting from 2020, we have a constitution for hemodialysis starting from January, and it's published already online, and we expect to have the copy within the next month. So while we are in the need of a guideline and what chapters and Egyptian versus internationals, and it is affordable or not, and applications and other questions and answers. So why we are in need of a guideline is different from the country constitution because it's applied in progress, and achievement and improvement is a continuous rather than the country constitution, which should be 100%. And the Egyptian guideline is a dynamic one, meaning that professors and colleagues are welcomed for discussion and the future editions, as well recording the feedback and the clinical practice in different centers is coming for these guidelines. E.g. NICE, it's a fitting puzzle for all the nephrological needs in hemodialysis service, starting from the flux, CKD, MPD, anemia, vascular access, safe ultrafiltration, and hemodialysis adequacy. So the guidelines that should meet all the patient's needs fulfill the three major pH in dialysis, which meaning that solid flux, physiology, philosophy of therapy, and physics of dialysis membrane. So we understand the hemodialysis procedures, and we understand the solids accumulation and the toxins. We are trying to manage our patient in the optimum care. So a guideline that should meet all the patient needs, improve quality of life, prevent organ damage, and preserve residual kidney function, plus survival as in renal transplantation. So if our dialysis improve anemia, prevent organ stunning, control bone diseases, minimal inflammation, and prevent cardiovascular disease is essential. And the nephrology initiative of care and excellence in its part one has a strategy, guide, and the monitoring, clinical performance monitoring. So hemodialysis prescription, it's a multi-dimensional way looking for the dose, metabolic profile, control of blood pressure, control of volume status, control of all patient needs, as well key points in nutritional and no inflammation. So registry team are our partner, and we all thanks the hard work they are collecting data from different centers. And when we are looking to the world around, it is growing so fast, going to the 5G and the digital health, and could be artificial intelligence be the answer to a plethora of many of healthcare problems. The art of data here, we have two types. We have to overcome the restricted data and the limited data. So we have to collect as much as we can from the data, and data is the only eliminating hope for improvement, non-restrictive and non-limited. We cannot fix what we cannot measure. So I hopefully that we can collect more and more data from different centers. When you look to Africa, Egypt won of the initiation of dialysis in 1964, and it's now 55 years on dialysis. We have sufficient structures. We have 100% MILI covered, full knowledge base, and as well manpower. So it's a 55 years. We have to start the quality management system that improve definitely the outcome of dialysis patient. The structure and manpower here, we look for the unit structure, human resources, to build up a unit with hemodialysis based on membranes, structure, vascular access, frequency, standard operating procedures, and as well clinical performance management. So both we are here looking for the unit structure, the manpower, the process of the hemodialysis, and then we can measure the healthcare outcome. The structures mainly, 10 points should be fulfilled. We have to put as well a clinic for nutritional, social, transplantation guide, technicians and nursing, discussion room, patient education, as well administration. This is a guide for structure of new units. As well, the educational process, we do a lot of educational material concerning the hemodialysis in depth. Teleconferences is usually active every week, thanks to Professor Hussein Shaisha for acting so active in the process of education, as well far away from education, any country can join Professor Hussein Shaisha. So while we are in need of a guideline, it's a hemodialysis guidelines, as well monitoring, and we have to do a monitoring, achievement, and improvement with specific domains. Once we start monitoring, we can discuss how to progress for better healthcare outcome. When you look to the DOPS, you can find that for each country, different parameters like anemia, vascular access, ultrafiltration rate, blood flow rate, and as well urea reduction ratio. This is published maybe every 3 months, every 6 months, or at least annually. So the measuring the outcome to the nephrologist need and true patient needs, and this is recently discussed in the New York Times, that patients are not interested in our KT over V. Patients need more service. True patients need can travel, enjoy hemodialysis 3 days, eat free, no pain, no depression, and no family nor social burden. Such guidelines should look as well for true patient needs, not only for nephrologist KT over V. So we have shortened lifespan, depressions, disabilities, and if we can do a dialysis with stronger people, we'll have a better outcome. Reporting each information will be of value, and our scope is designed to provide information and to optimize patient management to the excellency of hemodialysis therapy. EGNICE is here for and born to be personalized and to be individualized, and this individualization for high flux membrane. We don't recommend using any more of low flux membrane and should be personalized. And if you look to do the personalization of around 60,000 patients in Egypt, we have a planning, risk assessment, monitoring, identifying more patients at risk, and then you can individualize your patient for the, as excellently described, magnesium, potassium, flux, convection, time, frequency, as well as nutritional support. So why we are in need of a guideline? We have to have a guide for all center, unique book for all needed requirement, continuous improving evaluation of the centers, promoting high quality service using the utmost standard, and a plethora of clinical variables in between centers. This should be harmonized into a standardized therapy. We all thank Professor Dr. Adel Afifi, who more than 20 years, who started the registry, and we thank as well in Shams University for its publication 5 years ago on around 25,000 patients on dialysis for the using low flux KT over V, surface area of dialyzer, hepatitis C, and the others. We are very optimized for the great team of the registry to start their collecting data, then we can further analysis, registry, and improvement techniques. So why we are in need of a guideline? It is a scientific and regulatory, and here we want to do it. We want to do it. We are in the stage of we want to do a guideline to harmonize all the therapy. What's the chapters? It's a lot of chapters. It's out of the scope of this talk. It needs days to discuss chapters, but I will highlight very rapidly hemodialysis strategies in 15 points, starting from when to initiate dialysis and ending for the infection control and the rationale for hemodialysis strategies. Dialysis treatment options, And the differences between Egyptian versus the international guidelines, there is no difference. It is more or less in accordance to all the guidelines and publications all over the past 10 years. So thus this guideline is affordable, and it is very important in Egypt to implement a guideline, but the cost of the guideline is high. So direct cost and non-direct cost, intangible cost, and the other cost is equivalent between different countries in the disposables, but mainly in the direct cost, in the capital cost of building is a little bit lower, but all the medical devices are equivalent in between. We also have a challenge here. We lack of enough nephrologists. Country escape. And the cost in the middle income countries, when you look to other middle income countries, we found that we are so far away from this reimbursement rate. In Sudan, it's about 15,000 USD, while in Egypt, it's not more than 4,000 USD. And if you look to the European and the American or the Canadian cost of dialysis, you will find that 30% of the cost of dialysis is going to doctors and nurses. It's much more than the supplies, dialyzers lines. While in Egypt, it's very, very low, and this is maybe probably escape from a nephrologist. As well, patients with multiple comorbidities needs your attention because it will cost much and higher than usual. So the international guidelines saying that it's about 29% of the overall cost is covered by the government. The patient have to pay in many of the low-income countries, and that's why we didn't have up to this moment a PD program, because it's 5x the cost of hemodialysis. Not because PD is expensive, but because hemodialysis is too low, and it should be one-to-one cost, while in Egypt it's only 0.2 cost. So PD is 5x cost of dialysis than in PD. What and when we should start? We should start in 6 steps. We are here educating the point and starting to collect the data. We think that probably within the next 2 to 3 years, we can have more and more steps in the guidelines. So CPM, clinical performance monitoring, targeting improvement of care, and this is the final step for improvement of dialysis units. We can also have a total performance score, 15% for safety, 15% for reporting, and 70% for clinical, with multiple variables, around 10 variables scoring system that will be implemented in the next year. So the clinical measure centers, it will be like that. For each center, how many vascular access you have, how many AV fistula, and how bone mineral disease. So the selected topics, going back to the personalized medicine, we don't have a glucose containing dialysate. We have encountered for that, and as well we don't have a dialysate potassium of 3 millimole per liter. We have only 2 millimole per liter. As well, magnesium, as perfectly described, we don't have above 0.5 millimole per liter. So we need to have more plenty of medical device for fulfilling the personalized therapy. All in this guideline, it is for a high flux dialysis. No low flux anymore should be used. And our target of therapy and the goal of all the multidisciplinary guidelines is to redefining the adequacy means beyond urea reduction ratio to the goal of maximum quality of life and maximizing survival. Blood tubing as well has a good chapter. It should be avoided by DHP, which is a very toxic material, especially in pediatric patients. Implementing hemodiafiltration, when, whom, how, dose, and monitoring, and the guiding for patients with good vascular access or weak vascular access to do a pre-dilutional or post-dilutional, how to implement clinical logistics economics in steps. You can carry hemodiafiltration implementation in your unit, and adjusting the doses of hemodiafiltration to all the patient needs, in particular the patients on regular hemodiafiltration with a minimum of 23 liters per session. We also discussed in the guidelines the augmented hemodialysis, and this is the first time to describe the patient needs for augmented hemodialysis, especially in pregnancy. We also discussed the nutrition and how to improve the protein intake and nutritional supports, mineral requirements, trace elements, and against inflammation, sarcopenia, and frailty. We should think about that. And Professor Khamis will discuss the post-dialysis recovery time and how to overcome and improve the patient after hemodialysis. We also discussed in details the green ultrafiltration rate. So hemodialysis prescription, volume status, and ultrafiltration rate should be in a very limited to prevent organ stunning, especially the cardiac and the brain organ stunning. So we have to apply this ultrafiltration rate in particular for patients with comorbidities or cardiovascular disease. In the standard operating procedure or SOP, we have 15 points starting from the patient entrance till ending of the dialysis session, all what you need, how to manage your patient in home or in center dialysis. And also they discuss the topics from the guidelines, the manpower and the human resources, identifying all the human resources, speciality, job description or GD, and the responsibility between director, manager, and operator. So this is a strategy which is around 50% of the guidelines. Other additional guidelines is carried by many professors and very, very elegant professor, vascular access Professor Correi, all what you need in arteriovenous fistula, graft or catheter, how to manage, how to insert, how to protect, how to guard against infection, CKD, MPD, as well in details, anemia management with Professor Kamal Akash and Professor Huwaida El-Shinawi. All the deep thanks as well to Professor Yasser Abdelhamid for dialysis prescription in AKI, CRRT, SLED, and other techniques. Infection control policy to be implemented in all sessions and as well in centers, especially the hepatitis C gray zone and moving from the hepatitis C positive to hepatitis C negative, how to manage that by PCR and etc. So in conclusion, Mr. Chairman and dear colleagues, the Egyptian hemodialysis guideline is the firstly published this year, aiming to have a care and the beyond care and excellency for the nephrology initiative of care is part one. Second part for transplantation as well for glomerulopathy and hypertension is carried out here this few weeks later. And EG-NICE started to fulfill all the needs in hemodialysis prescription, monitoring for the best outcome. EG-NICE is simply all your need in your patients, just to orchestrating patients' need on hemodialysis with maximum care and the least cost, because we have in a very low income countries, and it's clearly required to start the rule and never be late. The constitution of Egyptian hemodialysis should be applied. And the cost management program should be in its optimum. And finally, it's my great pleasure to announce for our next hemodialysis Congress in October. This is the first in Shams University ESNT chapter hemodialysis in collaboration with the International Society of Hemodialysis. First Congress in the Middle East will be with very eminent international speaker in October 2020. Thank you all for a great team and a great work. Thank you.